I promise not to talk about the differences within South Africa. My talk is focused on low to middle income countries globally and what the role is of integrase inhibitor in that setting, with a particular focus on sub-Saharan Africa, and my talk is geared towards public sector. So what is the current state of antiretroviral therapy? You heard a little bit about this from Michelle, but we follow WHO guidelines with a standardized NNRTI-based first-line regimen, a boosted PI in the second line, and the current first-line regimen is Ephemerins, tenofovir, and XTC in a fixed-dose combination, and that's made a big difference, and patients who are adherent do extremely well. The current regimens are highly effective if you take them. However, one point that I do want to stress, and I'll return to this later, is that in many low-income countries, until very recently, there was no viral load monitoring at all. But even in an upper middle-income country like South Africa, viral load monitoring is done once a year. It's done at 6 months, 12 months, and then once a year. And that's provided the clinics actually follow the guidelines, and many clinics do not do that. So we are working in an environment where viral load monitoring is done very infrequently, and in some cases, not at all. And Michelle also mentioned that resistance testing within South Africa, a few other countries have introduced a third line, and it's not rational to empirically switch to third line. So we have resistance testing only for third line, but that's a tiny percentage of the population. So there is no resistance testing at the end of first line failure, and certainly not resistance testing before you start therapy. So I'm going to start the talk by focusing on what we have rather than on what we could have. And I've listed some properties here for regimens in resource-limited settings. The one in bold, as you've heard from Charlotte, that resistance barriers are extremely important, and Ephemerins, unfortunately, has a very low genetic barrier to the development of resistance. It's pretty well tolerated, certainly not initially, but I'll go into this in some depth because we have underestimated the long-term toxicity of this drug, especially in an African context. We have safety in pregnancy, we have low pill burdens, there's not much lab tox monitoring, many countries don't even do creatinine monitoring, and it's pretty rare to get acute kidney injury. And very importantly, the drug can be used with tuberculosis without any dose adjustment. That's a major plus, because about 25% of our patients in the Western Cape who start antiretroviral therapy have tuberculosis and are on TB therapy when we start. And about 5% per annum get TB while they are on ART, although that does depend on what their CD4 count is. Okay, so I'm going to first start with the resistance question. This is a review published a few years ago now, and there is a new one coming along from the WHO, but I think this trend is real, and I think this tells the story. In low to middle income countries, there is a trend towards increasing transmitted resistance. That is, patients who've never been treated before were infected with a resistant virus, and that has obvious implications for how they will respond to an empiric first-line regimen. You can see it's increasing over time in men who have sex with men, in people who inject drugs, and in heterosexuals. The error bars indicate that the population sizes aren't that big, but I think the trend is real. And there's some parts in Eastern Africa where primary transmitted resistance is seen in over 10% of people. So there is a trend towards increasing NNRTI resistance, and that's not surprising. People fail first-line therapy often for years before they are switched. So there is a very long period of time of viremia with resistant mutants, during which time transmission events can occur. And that, to me, is one of the most important reasons why we need to seriously rethink what we're doing in our first-line regimen. I'm going to spend the rest of the time talking about toxicity. This is a meta-analysis which was done by the WHO when looking at the first-line regimen. And as you know, in a forest plot, if it's on the comparator side, that favors Ephemerins. On the other side, it favors the comparator. And here we're looking at discontinuing a drug for toxicity, which is a good marker in clinical trials of more serious toxicity rather than just focusing on lab abnormalities or various grades. And amongst all the comparators, the only drug that Ephemerins was less toxic than was nevirapine. That's setting the bar pretty low. Even lopinavir, ritonavir, which is not well tolerated, had similar rates of stopping the drug for toxicity, whereas most of the other comparators, there was a difference favoring the comparator and showing that efavirenz is more toxic than a bunch of drugs, not just more toxic than integrase inhibitors. You're all familiar with the early neuropsychiatric toxicity that we see with efavirenz. Tolerance develops within the first few weeks, and this is a typical slide showing that by about 4 weeks, most of the early dizziness and vivid dreams are settled down and the patients are doing fine. And we were lulled by this kind of data into thinking that tolerance is complete and there are no long-term issues with efavirenz, or very few. Some people have to stop during this period, they develop psychosis, but only 2 to 3% in our clinics actually stop efavirenz in the first few months for this reason. This study was a pooled study by the ACTG published a few years ago showing that regimens containing efavirenz were associated with a long-term risk of suicidality. So it's not all over in the first 4 weeks. There is a long-term, low-grade, grumbling neuropsychiatric issues happening with efavirenz, which we've been underestimating and haven't really studied carefully enough. Recently, we've published a small case series of 20 patients. This is from a regional hospital, not a referral hospital, and they saw these 20 patients over a 2-year period. And an astute physician there picked up these women, came in, they were all women in this case series, although we have certainly seen men with this. They come in with an encephalopathy, with some cerebellar features. MRIs and CT scans were normal, lumbar punctures were normal, we didn't know what was going on. And eventually they started sending our laboratory plasma concentrations, and all of these women had off-the-scale efavirenz concentrations. We had to dilute the plasma in order to get a concentration for them. This was a late event occurring in women who'd been on it for more than 2 years, and 3 of them died. We've had 1 or 2 deaths in our hospital as well, people who come with a profound reduced level of consciousness, don't protect the airway, get aspiration pneumonia, and die. It is reversible. You stop the efavirenz and it slowly improves. So when you have a big denominator like we have, you start seeing these very uncommon adverse effects start popping up in the wards. And it's only recently that we've been recognizing that this is a syndrome at all. Efavirenz is generally thought to be a clean drug metabolically, at least in comparison with a drug like lopinavir. But in fact, the data is not very good. Dyslipidemia occurs more commonly with efavirenz than nevirapine, rilpivirine, atazanavir boosted with ritonavir, and integrase inhibitors. The fasting blood glucose with efavirenz was higher than with atazanavir, ritonavir in the ACTG trial. Only a small amount, but it was real. And we've done a couple of studies, observational studies, showing that dysglycemia, which is defined as an abnormal glucose tolerance test, was more common with efavirenz than with other regimens. And in a cohort study, overt diabetes developed more commonly on efavirenz than nevirapine. Efavirenz might also have an effect on bone. Efavirenz induces the metabolism of many drugs, but also induces the metabolism of vitamin D to an inactive form. So people on efavirenz have lower concentrations of vitamin D, and in one study that we did, only a cross-sectional study, but nevertheless we did find an association between low bone mineral density and use of efavirenz. So maybe in the long term there are some issues around bone that we've always been thinking about tenofovir, but there may be other drugs involved in bone health as well. It's well known that CYP2B6 metabolizes efavirenz, and that polymorphisms in CYP2B6 that are associated with loss of function increase the concentrations of efavirenz. And this graph was done by one of our PhD students, Puma Sinkadi, who is in the audience here, showing that as you accumulate more and more SNPs, so the concentrations of efavirenz increase, and they've been categorized into intermediate and slow metabolizer on the basis of their genotypes. And much of efavirenz's toxicity is in fact dose-related, apart from the early hypersensitivity events. The prevalence of slow or intermediate metabolizer genotypes in Africa and India and Thailand is about 5 to 10 times higher than it is in European populations, which is where the original pivotal trials were done. And I've listed here dose-related toxicity, neuropsychiatric. Hepatitis is also dose-related and has been linked to CYP2B6 genotype in a number of studies. Pumla also showed associations between concentrations and lipids and glucose. So there's more and more data emerging that the concentration of ephemerin's rather than the dose is responsible for much of the toxicity that we're seeing. And we're putting it in populations in large numbers where slow metabolizer genotypes are very common. So you all know this data. A few years ago, Dolutegravir was one of the first regimens that outperformed ephemerin's in terms of virologic efficacy in this pivotal trial. Most of the better efficacy was related to the fact that ephemerin's was not as well tolerated, but it should be noted that Dolutegravir does have some neuropsychiatric problems, and insomnia was actually more common in the Dolutegravir arm than in the ephemerin's arm in this particular study. You've heard from Charlotte about the high genetic barrier to resistance that Dolutegravir has, certainly much higher than the first generation integrase inhibitors, and that much of the resistance affects the replicative capacity of the virus, unlike the first generation integrase inhibitors. And the final point is a key one, is that exposure to the first generation integrase inhibitors, as in Michelle's case, does compromise Dolutegravir, and I'll return to this point a little bit later. Dolutegravir isn't the only kid on the block in terms of second generation integrase inhibitors, but it is furthest along. So I'm going to focus the rest of my talk on Dolutegravir, but I just want to spend a couple of slides pointing out that there are two others coming along, which may also come into the frame once we have more clinical data. The one is bictegravir, which is very similar to Dolutegravir in the small phase 2 study. This is a graph showing virologic efficacy. And the second one is cabotegravir in this phase 2 study showing good rates of virologic suppression. And cabotegravir is interesting because there are long-acting depot formulations that have been used in PrEP, but also in therapy. I didn't think this would be a great idea, and I didn't think patients would like it. But a couple of studies done in collaboration with these cabotegravir studies and other long-acting studies have shown that patients actually like it. They prefer getting an injection once every 4 to 8 weeks compared with taking pills every day. So that was a bit of a surprise to me, and it may be that more and more patients, given the option, would prefer to go on to long-acting depot formulations. But I think that's a few years away. What about tuberculosis? Well, I've already told you that tuberculosis is a big deal in low and middle income countries. Dolutegravir's metabolism is induced by rifampicin, as is the case with many drugs. And this study by Kelly Dooley showed that you can overcome the induction by giving Dolutegravir 12 hourly. You actually overshoot somewhat, and that the area under the curve is a little bit higher when you give 12 hourly dosing compared with giving once a day. So there is a dose adjustment which can be used. Kelly is also leading the Inspiring study, which is an open-label study looking at ephemerin's versus Dolutegravir, and here they're using the 12-hourly dose that she showed in her PK study. It's important to note, though, that this study is not powered for efficacy. This is not a non-inferiority RCT. It is really a phase 2/3 study where there's a control arm of ephemerin's just to make sure that the virologic suppression rates are reasonable. Kelly told me that her data would probably be out at the end of this year, perhaps at the European AIDS meeting coming up at the end of the year. There's a healthy volunteer study looking at more acceptable dosing of daily dosing of either 50 or 100 milligrams, and that healthy volunteer study will be starting early next year. So we'll know more about more convenient dose adjustments with Dolutegravir in the near future. So apart from TB, what are the other knowledge gaps in resource-limited settings? Well, although in their company-sponsored studies they didn't find an association between toxicity and exposure, that has been shown now in a small study which was presented at CROI. And that's relevant to us. It's relevant to us particularly in Africa because Dolutegravir is metabolized by UGT1A1, And loss of function polymorphisms in that gene are much more common in people of African compared with European ancestry. And by common, I mean 12 to 25% of the population. So we're not talking about a rare event. So much like Ephemerins, the story may be different in Africa than it is in Europe. Okay. We will see patients with quite a lot higher exposure on the basis of genetic factors associated with metabolism. The second issue is that women also seem to have a higher risk of neuropsychiatric effects, and women have higher exposure. And only 16% of the participants in the single study, which is the graph that I showed you, showing that dolutegravir was superior to Ephemerins, only 16% of those participants were women, which is something that you would think that in the modern era that companies would be a bit more sensitive to this. And there is a talk a little bit later about issues related to women. I'm sure that talk will also cover data in pregnancy, so I've not covered that. And you'll hear later in a separate talk about the need for pediatric formulations, which I'm also not going to cover, but I just want to raise them as issues that still need to be sorted out before we can roll it out. So if we look at the first-line regimens, I've put there 2 fixed-dose combinations of dolutegravir. Generic manufacturers have made dolutegravir, tenofovir in either 3TC or FTC. That's the formulation we want. We don't really want the abacavir formulation. Tenofovir is cheaper to manufacture, and that's the one that we are going to be moving forward with in South Africa at any rate. And I predict that once the South African market is open and the generic manufacturers rise to the occasion of 6.5 million people needing therapy, that other countries will also follow suit. And in terms of the desirable properties, the most important one for me here is the higher resistance barrier. It is also well tolerated. We do need some more data on TB, but we have a dose that we'll probably be able to go forward with once the inspiring study results are out, and I'm pretty sure that they will show reasonably good rates of virologic efficacy. But to understand more what's going to happen when you use this drug in an African population, Francois Fenter, who is Michelle's boss, is the PI of this study called ADVANCE, which is looking at the standard of care versus 2 other arms, both with dolutegravir, one with tenofovir and one with TAF. TAF is attractive in low and middle income countries because you only need 25 milligrams, and to manufacture that will be cheaper than manufacturing 300 milligrams of TDF. So there's a lot of interest in TAF moving forward. And this study has started enrolling at the beginning of this year, and I'm not sure when results are going to be available. I would imagine 2019, Michelle?
End of 2018, there should be fully accurate data.
Okay, so
Probably
CROI 2019, watch the space. What about second-line regimens? Well, I'm not going to go through these in any great detail. Most countries in resource-limited settings use lopinavir-based regimens. One reason for that is that there is a fixed-dose combination, although there is also a fixed-dose combination available from generics of AZT plus ritonavir. Some countries use that in preference because it is better tolerated. There's no doubt about that. But it's still not very well tolerated. A lot of patients developed visible jaundice and don't like that. You can double the dose of lopinavir with TB therapy, but that's not very well tolerated, but we have to do that, whereas there's no data at all on atazanavir. So what about using dolutegravir in second line? Well, it is true that boosted PIs are effective in second line, even though there might be high-level resistance to all of the NRTIs that they're taking. That's been well shown in a number of cohort studies and has clearly been shown in a sub-analysis which has recently been published from the EARNEST trial. And remember, I'll return you to my first slide, that this is in an environment where there's effectively no resistance testing available at the end of first-line failure. In these circumstances, dolutegravir may be effective, but we don't know that. And the recent data shown at CROI, and you'll hear more this afternoon about that, about maintenance monotherapy, where resistance starts developing on dolutegravir. You don't see that with the PIs, and I agree with Charlotte that the genetic barrier to resistance of dolutegravir is not as high as the PIs. I mean, my knowledge of this is as a clinician, so her knowledge of it is much deeper than mine. And I was delighted to hear her say that, because these data persuaded us that this is not as good as a PI. It's better than Dolutegravir, it's far better than the NNRTIs, but it's still not quite there. And we actually need an RCT, a real-life RCT, to be done before we can accept that. Now, the company have done a dawning study, and I hear there's going to be an interesting late breaker shown at the conference next week on this. But in dawning, they did resistance testing, and you could only get into dawning if you had one fully active NRTI. That is not real world. We are not going to be in that situation in sub-Saharan Africa. Maybe some upper middle income countries could consider it, but certainly low income countries can never never say never. There might be some smart chip one day that will tell us about NNRTI resistance and NRTI resistance, but for now, we don't have that available to us. So I don't think we should be promoting Dolutegravir in second line, even when the dawning study shows its very interesting results that watch the space. That is not going to be translatable into real-world circumstances yet. And unfortunately, we need to do a study to answer that. Would have been great if dawning had stratified them by this resistance, but I guess you need to take things one step at a time. What is the role of the first-generation integrase inhibitors? In my view, we should severely restrict them. This is not very popular with the companies that manufacture them. But you've seen the data. You saw from Michelle's case. This is a mistake. It's like using nalidixic acid, the old quinolone, because it was cheaper than the newer quinolones that came along, and you develop resistance, and then the resistance to the newer quinolones. And that was a mistake that many African countries made and many Asian countries made and are still making today. We don't want to do that again. I think there's still a role for them, because it is true that Dolutegravir has better data in pregnancy, and it is true that they have better formulations for kids. So perhaps until we have such data from Dolutegravir, there will be a small role for it. But in big programs, we need to make these drugs incredibly difficult to get or impossible to get, so that we don't interfere with their most attractive property to us, which is the high genetic barrier to resistance. So just to wrap up, I've hammered the point home. I think that Ephemerins is not ideal in terms of the high rates of transmitted resistance that we are seeing. We've underestimated the long-term toxicity, and we are working in environments, Africa, Thailand, India, where slow metabolizer genotypes are very common. And maybe the costs of these long-term metabolic things, which are mild, could be something that we would reap in 10 or 15 years' time. Dolutegravir is clearly a highly attractive alternative. This isn't just my opinion. Botswana has done that. Kenya is doing it. South Africa is going to switch to Dolutegravir probably at the end of 2018, depending on when there are enough generic manufacturers in the market to supply our enormous patient population. We do still need more data, and data from the advanced study in particular will be important, and we'll hear from other speakers about children and pregnancy. And finally, I've made the point about second line. We're already seeing a lot of pressure to use Dolutegravir in second line, but we don't think that that's a good idea, because we're not going to be able to get NRTI resistance data at a population level. Thank you very much.